Okay, good afternoon. My name's Tom Farden. I'm Chair of Grand Rounds today. I don't have any parish notices. The university has come to a bit of a grinding halt because it's the summer holidays, and I think the summer holidays have taken a hit on the Grand Rounds. Not as many people as we would normally expect, but that doesn't mean to say we won't have a good time. Matthew Checketts, who looks very dapper in this picture, doesn't he? We've extracted that picture from Google. He's just as dapper today. He's going to talk to us about preoperative anemia, etiology, diagnosis, and why you need to treat it. So without further ado, we'll just move on to the presentation in hand. Thanks very much.
Thanks, Tom, and thanks for coming today. Great to see you. I know you're just here for the sandwiches, but I'll try and make your munching as entertaining as I can. I'm the clinical lead for the surgical pre-assessment clinic at 9 Wells here, and a lot of what I've got to say is based on work that we've been doing there. But let's kick off with just to consider the issues with preoperative anemia. No pressure on me today, of course, because we've got haematologists here, we've got renal doctors here, and some of my own colleagues, and even some general practitioners I see in the room, so always nice to see you all. So I want to tell you today that preoperative anemia is definitely associated with increased perioperative mortality and morbidity. And also, I'm sorry to say that perioperative blood transfusion is also associated with both morbidity and mortality, and I'll show you some data to support that. And I hope on that basis I can convince you that there is a case to identify and treat preoperative anemia at the preoperative stage if possible, because that will hopefully improve outcomes, but more of that later on. I'm going to show you a clinical pathway that has been developed in our pre-assessment clinic to manage anemic patients and show you some of the data from that. Paul Greenwood was one of our FI1 doctors. He's going to speak at the end of this presentation and show some of our own data. But I guess the big question, which is yet to be answered, is does correcting pre-op anemia actually improve patient outcomes? And there is a prospective study going on called the PREVENT study, which we hope to participate in, a multi-centre study run from UCH in London via Toby Richards, which aims to answer that question, but we don't really have rigid data on that yet. So just to put, for those of you who don't know, in the picture of the pre-assessment service in Tayside, we have 3 pre-assessment clinics in Stracathro, 9 Wells and Perth. And we all one big happy family, and we all work together with very similar working practices and documentation. And our pre-assessment clinic here in 9 Wells is in area 5A on the end of the corridor, so please, if you fancy popping in and saying hi to us one day, please do that. It's a busy place, as you will see, because in the course of a year we see approximately 10,000 patients at our clinic in Dundee. We see about 4,500 patients in the clinic in Perth and about 3,500 patients in Stracathro, so of the order of about 18,000 patients across all surgical specialities. And we see most of these patients several weeks before their procedure. We try and see them as far upstream as possible in order to correct things like anemia and hypertension and poorly controlled diabetes and COPD and blah, blah, blah. So our model is slightly different to a lot of pre-assessment clinics in that we're seeing patients further up the perioperative pathway than other centres where they're just seeing perhaps a week or two before. So first thing to hammer home, I think, is the fact that pre-op anemia is bad and is associated with mortality. There are a number of studies I'm going to show you which might convince you. The first one comes from Toronto, Scott Beattie, in a single centre of consecutive elective patients, 7,700 patients. And you'll see 2 curves there, mortality curves. The red is men and the blue is women. And as you see, as the hemoglobin drops in men, the mortality increases. And similarly in women, interestingly, the curve is not such a straight line. It just takes off at about 12. And you see the definite increase in mortality as anemia worsens. So that's interesting. So the odds ratio of death in that population with severe anemia is over 2. And transfusion was 3 times more likely in anemic patients. More data to follow. There's another important study from the US, from Musallam, published in the Lancet 2011. Over 227,000 patients from a US database, National Surgical Quality Improvement Program, very well controlled and well kept up to date database, looking at the effects of anemia on post-op outcomes in non-cardiac surgery. And there was no doubt that anemia was associated with increased mortality and morbidity, even mild anemia. 30 to 40% increased risk in mortality across all types of surgery. And obviously they concluded that there was value in treating anemia. And this is a graphic from that study. And just to explain what this graphic is, it shows mortality on the y-axis against a range of different risk factors. The bars in red were patients who'd had neither anemia nor the risk factor, so controls. The orange bars were patients who had either anemia or the risk factor. So there's the orange bars there. And the blue bars were patients who had risk factor and anemia. So interesting, you see that there's quite definite increase in mortality if either risk factor or anemia was present, and if you had both, it was amplified. And the top three in terms of increased mortality were renal disease, sepsis, and COPD. Not surprising, but quite dramatic. Another study from Europe, the European Surgical Outcomes Study, 39,000 patients, elective patients, non-cardiac surgery patients. This is a prospective secondary analysis from some other data. And again, they found the same thing, that moderate anemia is associated with a doubling of mortality, a longer hospital stay, and a significantly increased use of critical care beds. And this is the graphic from that study, and you see it's a very similar shape to the curve we saw earlier on from the Toronto group, where mortality in blue takes off once anemia starts to kick in, and we see the mortality rate just increasing there. So the same things are coming from different databases and different populations. In another group looking at colorectal surgery specifically, 23,000 patients, the same database, longer hospital stays, higher 30-day adverse events, and you see a sort of dose-response curve in terms of morbidity and the odds ratio of complications. Same thing. What about Scotland? Well, here's arthroplasty patients. This is looking at the prevalence of anemia in preoperative arthroplasty patients across all the different hospitals doing joint replacement in Scotland. You can see the incidence of anemia, which is in the pink, varies quite significantly between different centres. So the ones that seem to have the highest incidence of anemia are things like the Southern General Hospital, Elgin for some reason, where else? And the Royal Infirmary of Edinburgh. And you see there's a difference between Perth and 9 Wells. The incidence in Perth seems to be significantly lower in that population than our population. So lots of studies show that in arthroplasty patients, the incidence of anemia is up to 30%. So it's quite significant, and this is typical of lots of surgical populations. So the question is, what is the impact of the anemia on the rate of transfusion in arthroplasty patients? So this is from the same Scottish audit, looking at the percentage of patients who had a blood transfusion after hip replacement. And you see it varies again quite widely, but what we do know is that anemia is associated with a significantly increased risk of having a blood transfusion. And it varied a lot. So Monklands, for example, had a transfusion rate at that time of about 30%. Whereas other centres like the Golden Jubilee Hospital, which have quite an aggressive system of perioperative blood management, have a very low transfusion rate. These are the same sort of patients, but different rates. But the other thing to note is that the rate of transfusion in this patient population is reducing from 2010, 2011. The general trend is down the way. So that's encouraging. We're becoming more aware of the need to manage anemia preoperatively and limit postoperative transfusion. This is an old slide, but it just really reinforces the fact that the more anemic you are, the higher the chance of you needing a transfusion. I think that's obvious, and we understand that. So blood transfusion, well, if they're anemic, maybe just give them a blood transfusion. That's a pretty safe and harmless thing to do, is it? Well, no, it isn't actually, because there's no doubt that transfusion is associated with mortality, more infections, wound problems, delayed healing, and hospital stay. Now, is it a causative effect? Is it an association? That's debatable, but the association is strong. Here's some work from Denmark, they collect data on all their joint replacement patients in Denmark. This is a cohort of 28,000 patients after hip replacement. A third of these patients were transfused, and it looked at the complications you see in the graphic there. And on the right-hand side, we have patients who had blood on this side, and these are patients who wouldn't have had blood. So you see, essentially, the critical thing there is that death and pneumonia, two pretty important complications after this type of surgery, is strongly, significantly increased in patients who've had transfusions. The other complications you see there, particularly DVT, cardiovascular and cerebrovascular disease, were associated with transfusion but did not cross the line of equivalence. So we can't make any conclusions on that. So anemia is bad, transfusion is not so good. What about if you just have to give 1 unit of blood? Surely 1 unit of blood is not going to do any harm to anybody, is it? Well, here's a study from Ferraris in the Archives of Surgery 2012, and it looks at the effect of giving transfusion, even moderate amounts of blood, in patients having surgery. And if you look at this graphic here, this is on the left-hand side, we've got patients who had no blood, and these patients had just 1 unit of blood. So, and look at the difference incidence in mortality, wound complications, and so on. It's quite significant. It's quite startling. So, what did they go on to say, really? Well, what you can see here is as you give more blood, you get a dose-response curve in terms of mortality and morbidity. So mortality is in black, more blood, and morbidity is in the white bars. So almost a dose-response curve in poor outcomes. So they concluded that even 1 unit of blood is best to avoid if you can. If you have to give a blood transfusion, fine, but if there are other ways of avoiding it, great. Think carefully before you toss in that unit of blood because the patient's hemoglobin is a bit low and they're looking a bit pale. Well, are there any national guidelines to help us manage these patients? Well, there are, and this is a website which I commend to those of you who don't know about it, the British Committee for Standards in Haematology. If you just Google that, you'll get it. There's lots of useful guidelines on there on all kinds of hematological things, and they've obviously produced one on preoperative anemia. So what did they say? Well, surprise, surprise, they've kind of said what I've said already. Anemia is associated with the risk of transfusion, it's associated with morbidity and mortality, as does transfusion. So let's develop pathways to manage these patients carefully, and let's talk to patients about the risk of anemia and explain to them why we need to be fairly aggressive about treating it. So in anesthesia and preoperative medicine, we've developed pathways, patient blood management pathways, which is a kind of three-pronged approach to minimize the need for transfusion as far as possible, for the reasons I've said already. And the pillars of that really essentially are fairly aggressive identification and treatment of preoperative anemia and optimizing hemoglobin as far as possible, even mild anemia, which perhaps we used to ignore in the past. During the procedure, let's try and reduce the bleeding by using minimally invasive surgery as far as possible, using drugs like tranexamic acid to reduce preoperative bleeding, which we use routinely in arthroplasty and trauma surgery now, and where appropriate, use cell salvage techniques, for example, major trauma, liver surgery, that sort of thing. And post-operatively, in the preoperative period, let's remember the patient has a significant physiological reserve, so they can tolerate anemia without coming to harm. And the FOCUS study, which looked at liberal versus restrictive transfusion patterns after hip fracture, found no difference between a restrictive threshold of 80 versus 100 in hip fracture patients. And these patients are, with lots of comorbidities, elderly, and have other issues to consider, so they can tolerate that. Now, I don't need to tell this audience about the etiology of anemia, and I don't want to insult your intelligence, but essentially a lot of it is iron deficiency anemia, and a lot of it is also sort of complex anemia of chronic disease. And I think we need to change that name to anemia of chronic inflammation, because essentially what we're looking at there is a kind of functional iron deficiency. There are obviously other causes, renal causes, and the hemoglobinopathies, which are out with the scope of this particular lecture. Iron deficiency anemia, which we're interested in, is rarely nutritional in the Western world and is frequently related to blood loss, either from the GI tract or related to the type of surgery the patient's coming from. But let's not forget that we pick up a lot of occult anemia in postmenopausal women and men over 50 that we have to investigate, because 10% of them may have cancer. So we refer to our gastroenterology colleagues if we pick those up. We see a few of those every year. The anemia of chronic disease or chronic inflammation, which I mentioned earlier on, is related to a problem of iron homeostasis and iron recycling. So these patients have normal ferritin, typically with a shorter red cell life, and they have reduced secretion of EPO. And it's mediated by the inflammatory cytokines, interleukins and TNF. And the key hormone polypeptide is hepcidin, which you probably know about, which is secreted from the liver. And it's key in iron homeostasis. It binds to ferroportin. I'll show you a graphic. Ferroportin is a transmembrane protein which allows iron to come out of enterocytes and out of macrophages in the reticular endothelial system to allow it to be delivered to the bone marrow where new cells can be made. And in chronic inflammatory states, hepcidin levels are up to 100 times normal. And again, hepcidin is an acute phase protein, so in any inflammatory state, including aging, which is pro-inflammatory by the way, hepcidin levels are higher. So we see the graphic here. Hepcidin is produced from the liver, and it denatures ferroportin. So that's why these patients don't respond to oral iron therapy, because the iron will get into the enterocytes, but it can't get out. And similarly, most of the iron, our iron stores are within the red cells and come from red cell destruction from macrophages. And again, the iron gets sequestered in the macrophages and can't get out because the ferroportin is damaged. So you see the profound effect that increased levels of hepcidin will have on the ability to respond in anemia. So I said already that aging is a pro-inflammatory process, I'm sorry to say, as I get older, and that's why anemia is more common in older patients. So it's about 11% in 65-year-olds, it's about 1.5% in men under 40, and if you look at nursing home residents, it's approaching 50%. And you can also show by doing activities of daily living and quality of life measurements that even mild anemia, say a hemoglobin of 120, have worse functional capacity than someone with a hemoglobin of 135. You think, wow. And you can show performance improvements in these patients if you boost their hemoglobin from very modest anemia from 120 to say to 130. So it is worth being aggressive with these patients. And I guess the bad news for the young doctors in the room is that we're getting older. And if we look at the Office for National Statistics figures, we see from this graphic that by 2033, the number of patients over 70 will increase by about 50%. The number of patients over 80 will nearly double, and the patients over 90 will more than double. So that has major implications for healthcare for all of us, I guess. I'm not sure we're actually geared up to deal with this tsunami of aging. So anyway, back to our clinic. As I say, we're seeing lots of patients across all specialities for all different types of surgery. So we have a system, so when the patient gets a full blood count, if they're anemic, there'll be some automatic additional tests that are done. So we get a film, a ferritin, a B12 and a folate, which is useful to help us make the diagnosis. Our nurses will pick up abnormalities and they'll be flagged up to one of the medical staff to decide what to do with them. And I guess that depends on what the etiology is. And then we use a pathway. I'll show you a pathway which you can't read. That's okay, because I've made a simpler one for you to look at. So I've simplified this. So if we get an anemic patient, if they're iron deficiency, i.e. low ferritin, and they're not urgent surgery, for example, hip replacement or hernia repair, we will give them oral iron and we'll contact the general practitioner and we'll arrange to follow them up in our clinic for an FBC at 3 weeks. We initially devolved that to general practice, primary care, but my wife's a GP, so I know how busy GPs are, and there are lots of other things to think about in primary care. So we see most of our patients back for a follow-up FBC. They don't need an appointment for that. And if the hemoglobin has improved, that's all fine, off we go. If the hemoglobin hasn't improved, then we have to think again. Can we live with it, or do we need to consider a trial of intravenous iron? And Paul is going to give us some data about how these patients actually respond. After intravenous iron, we usually follow them up after about 1 week or 10 days for a follow-up FBC. If they're iron deficient and they're having urgent surgery, cancer surgery is a good example as a short date until their operation time, because we're all under 12-week pressures, we'll give them IV iron to start with. And similarly, decide what to do, whether they respond or not. If they have a renal anemia, we talk it over with our renal colleagues. This is a very smaller number of patients, because these patients might benefit from erythropoietin-stimulating agents in addition to intravenous iron. The intravenous iron, incidentally, is administered by our colleagues in the CIU. They're very helpful, and it works pretty well. We don't have the facilities to give the iron in our clinic at this time. If patients are already on oral iron, let me go through that again. If they're already on oral iron and not responding, or time is pressing, then we might move on to intravenous iron. Intravenous iron has a cost, of course. It's not the cheapest drug out there, but it's cheaper than blood transfusion, and it's cheaper than a morbidity or mortality statistic. At the moment, we will give patients prescriptions. We'll send them prescriptions for iron the old-fashioned way, but we're about to go into electronic prescribing, which will make life a bit easier. This just cuts out a step with the general practitioner, but we always contact the general practitioner so they are in the loop, as it were. Intravenous iron is more rapidly effective than oral iron, but oral iron will get there in the end. This is a perinatal, antenatal study, and you see that oral iron will have an effect within about 1 to 2 weeks, whereas oral iron might take up to 40 days to get to the same point. We favour Ferinject because you can be given a large dose and be given in one go. You can be given it quite rapidly. It has a very low incidence of adverse reactions. Patients occasionally need a second dose, but usually not. And the CIU deliver it for us. And there is a cost, but don't tell anyone. Does intravenous iron work in terms of increasing hemoglobin? Does it work in terms of reducing blood transfusion? Well, yes, it does. This is from Ed Litton and Melbourne systematic review and meta-analysis. Sure enough, it does do those things. But interestingly, found a small increased risk of infection in patients with intravenous iron. And there is a theoretical increased risk of infection with high plasma iron levels. He debated the clinical significance of that, but I think it's worth mentioning. So, enough of that. I think we've made the case that anemia is bad and transfusion is bad. How does our clinical pathway stack up? So I'm going to hand over to Paul Greenwood just to give us a few slides about how our system has been working over the past 6 months. Paul.
So, hello everybody there. I'm Paul, FY1 in the Pre-assessment Clinic. So I'm just going to talk you through some of the data between December last year and June of this year. So we'll start off looking at the cohorts that we treat, and then have a look at the response rates, and then finally have a look at what kind of hemoglobin change that we see, what kind of bang we get for the iron treatment. Okay, so we'll start here. So you'll see from the interquartile range of the female population that on the whole we treat the younger females. You also note that the age range in the female cohort is much wider, down to ladies in their 20s. When compared with the men, and perhaps you can expect that since females have a few more causes to be anemic. So then, looking at the numbers, so how many people do we actually treat during this snapshot? I've not been able to include all the ones from June here because some of them at the time of collecting this data weren't actually followed up at this point. But I'll present what we had in terms of follow-up. So we've got 24 males in total, 34 female. And you can see here we treated 14 gentlemen with oral iron, 22 ladies with oral iron, and IV it's 10 and 12 respectively. And there's a small number that failed oral iron and were thought to, thought it would be appropriate to take them forward and then give them IV iron. Okay, so what kind of numbers respond to the HP? To the iron rather. So on the left here we have the oral iron numbers. So this is anyone who had any increase in HB after treatment. Okay, so we can see in the gentlemen, 64% of gentlemen responded, and 91% of ladies. Compare that with the IV. The gentleman had a 90% response rate, and only a 70% in the female cohort. And perhaps we can talk a little bit later about the reasons that this might have occurred. Okay, and then finally we'll just have a look at the kind of increases that in hemoglobin that we actually get after treatment. So this is all patients, including those who responded and who didn't. What's the kind of average HB increase? So orally, the average kind of time to follow up was 34 days. In that time, we saw an average increase of 8 grams per litre. Whereas IV, as we might expect, it's a bit greater at 13 grams per litre. So just on the last slide, what I've done is separated out the responders from the non-responders, and so this is the people who responded who had any increase in HB after treatment. And you can see here, if you were sensitive to iron treatment, it's on average 10 grams per litre in the oral cohort. Obviously, the 34 days, it takes longer to treat, and sometimes we have a problem getting people back to clinic or the GP, so it ends up being about 34 days. And then with the IV, 20 days, and we get a much better response at 17 grams per litre. So roughly akin to 1 unit perhaps of a transfusion for oral, and more analogous to 2 in the IV cohort. Okay, so that's the data. And just in summary, so we talked today about anemia and transfusion both being associated with worse preoperative outcome. We've discussed the case for being important to identify and treat pre-op anemia as soon as possible. And we've talked about how we treat with oral first, if there's time. In cases perhaps such as cancer or more urgent surgery, then IV is deemed to be more appropriate from a time perspective. Results show that the IV pharinject is well tolerated, and as we've seen here today, is effective in our cohort. Okay, and it's in conversation with renal physicians, the consideration of erythropoietin stimulating agents is thought to be useful in patients with renal disease, those who have been unresponsive or have this anemia of chronic inflammation, and also patients with complex antibodies in which transfusion would be more difficult. Okay, thanks very much. I'll now hand over to Dr. Checketts to field some questions.
Thanks, everyone. Thanks, Paul. Don't leave the stage. So I'll take comments, questions.
Okay, so we've got some haematologists who can give some opinion on this, and some fellow anaesthetists who might be able to tell us about...
Be kind to us haematologists.
So what kind of...
We're simple beings.
Because what kind of things happen if you don't sort out haemoglobin in the middle of operation? I'm just going to find a microphone. David, give me a sec. Well, then the Perth person can't hear you.
Oh, yes. Yeah. The Perth person.
There you go.
It's actually a simple question. I just wondered if you knew the outcome in terms of what the subsequent cause of the iron deficiency was found to be. Are you able to get an idea of how many people?
Well, usually, the thing is, you can usually guess. For example, if they're coming for TURBT, is probably from the bladder. If it's colorectal, it's that. If we're not sure, we will refer gastroenterology for investigation. So we can usually guess. And then there's obviously lots of anemias of chronic inflammation. Again, you can usually kind of associate that too. So we are treating quite a lot of what you perhaps regard as trivial anemia, and but I hope I've made the case of why we're being so fastidious about that. So the other question is, should we treat all the patients like that, or should we just concentrate our efforts on patients who are having bigger surgery with perhaps the possibility of losing more blood? I mean, should we spend a lot of time treating someone with a mild anemia who's having a carpal tunnel decompression, or should we be looking at the patients who are having, big surgery?
What's your feeling on that then?
I think we should probably do the latter now. I think at the moment we've been treating everybody, but I don't see the point of, if someone's got a hemoglobin 118, a woman's got hemoglobin 118 and she's coming for hand operation under tourniquet. There doesn't seem much point in being aggressive and delaying her for that reason. On the other hand, if she's coming for hip replacement or colorectal surgery, perhaps we should. So I think we should probably change our emphasis a little bit.
Because you've seen thousands of people in a year, and then the number of people you've given iron to was small number.
Yes,
but do you think that that seeing everybody like that has been worth it?
Time will tell. I mean, I think the evidence to suggest there's a strong association in poor outcomes with anemia and transfusion is convincing. Whether it's causative is debatable, but essentially what we're looking at here is, particularly patients having major surgery, is their ability to cope with stress, and we're talking about oxygen delivery, and so that's why you put them on CPX machines to look at their ability to deliver oxygen to the tissues. And if your hemoglobin is reduced, obviously that's a major factor in compromising that, on top of the cardiovascular compromise. So intuitively you can see why anemia might be bad for patients having major surgery. I think the PREVENT study might help us to answer some of those questions, but we certainly need more prospective, well-designed studies to actually prove that aggressively treating this anemia will make a significant difference. I think it will, but we're still to find out.
I hope you've got some more interest.
Yeah, there seemed quite a high proportion that needed to go to IV iron, but I suspect a lot of people that come for bowel surgery or TURBT, as you say, the GP would have picked up anemia, put them on oral iron, and you've got a bit of a select group that have then failed to respond to that. It's just for the audience thinking, oral iron fails at that rate, whereas oral iron will treat 95% of people quite adequately, whereas it looks there like it fails in about half of people. So these are people who either genuinely don't respond well to oral iron or in most cases don't take it.
Yes, and interesting, the women responded better than the men, I guess for the reasons because more of them had a pure, genuine iron deficiency anemia. The other question that's been raised, certainly south of the border, is should this be brought into the commissioning process from primary care trusts to say that before you refer the patient up for surgery, make sure the blood pressure is okay, make sure the diabetes is sorted out, and make sure they're not anemic. We've got Gordon McLean in the room. I don't know what he thinks about that. But we work in hand with primary care, and that's why we like to see patients far upstream. It's a partnership. It's a collaborative.
Thanks, Matthew and Paul. Do you have a feeling for, at the other end, post-operatively on the surgical wards, in relation to our transfusion thresholds? Are we getting better at that, or are we sort of managing that dilemma with the post-operative hemoglobin sitting at 80 odd and...
Well, I think the evidence from the Scottish arthroplasty audit suggests that we are. You look at the transfusion rates after this type of surgery is falling year on year. I think we've still got a wee way to go with it. And I guess sessions like this and help to educate people about, think twice before you just give 1 unit of blood. And if you're going to give some blood, give 1 unit of blood and then recheck the HB. Don't just say give 2 or 3 or 4 units. Without thinking. So I think we need to be a little bit more canny and reserve blood transfusions for patients who really need blood transfusions. Some patients do, of course. So I think we're getting better, but there's still a way to go. It's a simple answer. But I think for sure, if you start with an anemic patient and you do a big operation on them, the chance you give them a blood transfusion is doubled or trebled.
Obviously, anemia is only one part of your pre-operative assessment. Have you picked up on what other things are predictive of a poor outcome? I have a chap in medical HQ at the moment who has an albumin of 10, yet my surgical colleagues are very keen to operate on him. And I would have thought that would be a fairly poor prognostic marker, but that's just I'm just guessing.
No, you're absolutely right. Yeah, sometimes we have to temper the surgeon's enthusiasm to operate, and that's part of our job, and we're trying to optimise as much of the patient as we can. So that means, if your HbA1c is high, we will work with the specialist diabetic nurses to sort that out. If your hypertension is not well controlled, we'll work with primary care to sort that out. Anemia we've talked about. COPD, we might have conversations with people like yourself. We might do additional investigations to make difficult decisions like cardiopulmonary exercise test or myocardial perfusion scans. And sometimes we have difficult conversations with patients and saying, I know the surgeon says you should have the operation, but we're not sure this is in your best interests. And it's interesting what Bruce Keogh said last week, that 1 in 7 elective operations are not indicated, and perhaps the NHS is trying to do too much to too many people.
Okay. I still think the guy's albumin's a bit low, for tomorrow.
I agree. I agree. But how do you get someone's albumin off? That's a tough question, isn't it?
Yes.
You don't just pour albumin into them and they get better.
Anyone else got any comments they'd like to make? Paul, you were hovering. You've got
quickly
the
mentioning.
whole microphone set there.
Joe, just coming back to the point about perhaps our data doing oral iron a bit of a disservice from the kind of comparatively large number of IV treated. It's worth saying that in some cases we do pick up new anemia that hasn't necessarily been treated earlier. So some of those numbers will be new diagnoses which are also have a kind of prescient sense of urgency about the operation, and therefore in the interest of time rather than treatment modality they get treated with IV. So some of those numbers will be for that reason.
I mean, sometimes you've got to be pragmatic, you know. I mean, and that's where the expert and consultant opinion comes in. You say, well, okay, the hemoglobin's a bit low, but looking at everything in context, we can let that one slip through. So it's not a kind of monolithic pathway that we follow, you know, blindly. But I think by and large we're getting it right. I think it needs a little bit of refinement, but I think we can see some of the benefits in terms of optimizing hemoglobin already. Okay.
No more comments or questions? Then we'll call things to a conclusion. Next week, Drew Henson's going to come and talk about the paperless reporting, paperless requesting, paper switch off, saving the trees that we're going to do imminently. And I think that's a very important subject, because if you don't know about that, then one day you're not going to be able to request any tests. And the week after that, the Medical Education Institute are going to talk about a new way of teaching called Teach Me Meet, which I have to say I don't know a lot about, but we need a big audience, so I think there's going to be a practical. Thanks very much to Matthew and to Paul for coming. Thanks for taking part, and we'll see you all next week.